Now let's talk about syphilitic heart disease, high yield. It is tertiary syphilis disrupts the vasa vasorum of the aorta with consequent atrophy of the vessel wall and dilation of aorta and valve ring. May see calcification of aortic root, ascending aortic arch, and thoracic aorta. Leads to tree bark, high yield tree bark appearance of the aorta. Can result in aneurysm of the ascending aorta or aortic arch or aortic insufficiency. So what is all this all about? It is all about tertiary syphilis, which would disrupt the vasa vasorum of the aorta. And when you disrupt the vasa vasorum of aorta, you are going to cause dilation of aorta. If you recall back again that you have in a vessel you have intima, media, adventitia, right? And aorta being a big vessel, big artery here, it has the media, which is pretty big. So intima gets the blood supply from right away from the lumen here, right? The blood is here, it supplies intima. So let's just draw intima, media, adventitia. So intima gets supplied from the lumen right here, right? Media and adventitia, they need vasa vasorum that would give the blood supply to the big wall, muscle wall, media, and also the adventitia. So when you disrupt the vasa vasorum due to tertiary syphilis, what it's going to cause is going to cause dilation of aorta. So it's going to cause dilation of aorta. And I'll mention how. And the valve ring. So this is dilation because not getting blood supply. So later on what you will see is calcification within the aortic root, either the root where the aorta starts, it is dilated, okay, or the ascending. So let me erase this and do it here like so. You have left ventricle, here's the aortic root dilation, it is dilated, or the ascending aorta being dilated, or even the thoracic aorta being dilated, okay. And why all that occurred? Because you're not giving enough blood supply and it is going into aneurysm, a dilatation, right? Dilatation of the ascending aorta or aortic arch or aortic insufficiency. Okay, so this is all due to the fact you have tertiary syphilis. Okay, let's just review this. Tertiary syphilis disrupts vasa vasorum, causes dilation of aorta. Where can that occur? It can lead to calcification or can result in aneurysm of that ascending aorta, aortic arch, and cause aortic insufficiency. High yield with this tertiary syphilis vasa vasorum, you're going to see tree bark appearance of aorta. Okay, and that is all for syphilitic heart disease. Now let's look at the next topic, which is acute pericarditis. Acute pericarditis is inflammation of the pericardium. Red arrows in A. Let's erase this. We have this as the red arrow. Okay, this is here is the acute inflammation of the pericardium. Commonly presents with sharp pain, aggravated by inspiration, relieved by sitting up and leaning forward. High yield. Pericarditis has a pain that can be relieved by sitting up, leaning forward. Okay. And that is basically what you have is which is aggravated by inspiration, relieved by this. It is called pleuritic chest pain. Pleuritic chest pain. Okay, is often complicated by, now this acute pericarditis, which is just a simple inflammation of the pericardium, can be complicated by effusion, which is yellow, between the yellow arrows in picture A. So we can see, let's just zoom in here, see the difference. So here we just have inflammation of the pericardium, we don't see a proper fluid, like no black fluid. Just if you look here, you see a proper black without any proper black fluid, right? So this is your effusion fluid, but here is just something. We call it inflammation. And here's a proper fluid. Okay, so acute pericarditis, as I was saying, it is complicated by, let's change color, complicated by effusion, which would present with friction rub. Okay, what is friction rub? Friction rub is high-pitched, leathery, scratchy sound. Scratchy sound. That's called friction rub. And that is specifically for what we said, pericardial effusion. When we have a pericardial effusion, we will see friction rub, which is a leathery, scratchy sound. Okay. Now ECG, let's change color here. ECG changes include the widespread diffuse ST segment elevation and or PR depression. So what did we talk about when we said when we see ST segment elevation, ST segment elevation, STMI, or when we look at ST segment elevation, we think about MI, right? But here, when we see diffuse widespread ST segment elevation with some friction rub or with chest pain, pleuritic chest pain, we will think about pericarditis complicated by pericardial effusion. Okay, and or PR depression. It is usually idiopathic, but maybe due to viral infections. And like, what is the cause of this inflammation, right? I mean, it's not. There has to be something idiopathic, great. But what else? Viral infection, Coxsackie B, malignancy, METs, cardiac surgery, thoracic radiotherapy, early. If thoracic radiotherapy is early, there must be late something. We will talk about that. MI, cause example, post-cardiac injury syndrome, autoimmune diseases like SLE, rheumatoid arthritis, renal failure, uremia. So there could be any cause. You see, I mean, if you try to memorize all of them, what are you going to get? I guess you'll be able to know, okay, MI causes pericarditis with Dressler syndrome, post-cardial injury syndrome. Autoimmune could cause it. SLE, rheumatoid, renal failure, uremia can cause it. Coxsackie B, all of these are things that can cause it. Treatment is NSAID, colchicine, glucocorticoid, or for uremia, do dialysis. Okay, so now what is the important thing in all of this? That is basically, let's just go back a little bit here. We said acute pericarditis. Acute pericarditis, most common type is, for acute pericarditis, most common type is fibrinous. Fibrinous or serofibrinous pericarditis. And on your physical examination, you will see if it gets complicated by pericardial effusion, you will see friction rub, high yield. Okay. Inflammation of the pericardium, simple thing, right? If that inflammation extravasate to a great deal of fluid, meaning there's a great deal of fluid, so much fluid, then it's going to cause cardiac tamponade. And what was tamponade again? Tamponade was we had a fluid within the pericardium, but a great amount of fluid that was restricting the heart to not throw out a cardiac output, to decrease the cardiac output, right? And that was cardiac tamponade, to a great amount of fluid. So inflammation of the pericardium that causes a lot of fluid to go into the pericardium will cause cardiac tamponade. But if the cause of pericarditis is chronic, when the cause is chronic, for example, you have metastasis, for example, you have autoimmune disease, If there's a chronic cause, for example, in the after cardiac surgery, you develop a chronic pericarditis. These are all the chronic causes. The patient with the chronic cause would develop fibrosis, right? Or anything with the chronic, what's going to happen is there's going to be calcification, fibrosis. So fibrosis and calcification. And why am I mentioning this thing here? Because with the chronic cause, fibrosis, calcification, it's going to cause constrictive pericarditis, which is right here, constrictive pericarditis. So now let's also look at constrictive pericarditis first, since we were talking about it. So what is constrictive pericarditis? With the chronic inflammation of the pericardium, the pericardial fibrosis occurs, plus minus calcification occurs, that leads to limited space for expansion. So here you have a heart, and this is your pericardial space. Now there is a limitation of the expansion of the left ventricle, let's say. That's going to cause decrease in the ventricular filling, right? Usually idiopathic, but maybe due to viral infections or cardiac surgery, thoracic radiotherapy. Here's the late. So if you persistently give radiotherapy, thoracic radiotherapy, you're going to cause chronic inflammation, and that's going to cause constrictive pericarditis. But if you give radiotherapy acutely, just for a couple of weeks, what's going to happen is it's going to cause acute pericarditis. Tuberculosis, the most common cause in the resource-limited countries. Okay, that's there. Because you can't fill the fluid in the left ventricle, you will have decrease in the end diastolic volume, which will decrease the cardiac output, which will decrease the venous return, because there isn't much going out of the heart, so the return is also less. Constrictive pericarditis will present with dyspnea, which is shortness of breath, peripheral edema, JVD. Because you're not pushing the fluid out, what's going to happen is everything is just backing off. JVD, also JVD, peripheral edema, dyspnea, Kussmaul sign. Pulsus paradoxus again is here. What was pulsus paradoxus? Recall that. That was basically when you inspire, you are going to decrease the systolic blood pressure to greater than 10. Decrease greater than 10. For example, from 120, you're going to go to 110, or greater than less than 1, greater than 10, meaning, again, from 120, you went to 110, okay? Meaning there is a decrease in about 10 mmHg. You can't see that. Okay, now you can. Okay, and pericardial knock is the last thing. So now go back. Let's talk about what we were talking about. So inflammation of the pericardium, simple thing. Pericarditis, simple thing. No rocket science about it, right? But if there is a great amount of fluid that goes into the pericardium, what's going to be? It's going to be tamponade. Why it's going to be tamponade? Because you are not letting the left ventricle to push it out the cardiac output. So it's going to be a tamponade, because it's a great amount of fluid which is sitting in the pericardium. But if this inflammation becomes chronic, meaning you have persistent inflammation due to some of these risk factors, what's going to happen is you're going to cause fibrosis and calcification. That's going to cause constrictive pericarditis. What is going to be constrictive pericarditis? Similar to your tamponade. Why? Because you have decrease in cardiac output. But here it's going to be chronic. With the tamponade, you can do the pericardiocentesis and take the fluid out, and you're good to go. But here it's chronic. You can do nothing about it, right? It's chronically calcified constriction with calcification of the pericardium. On top of that, so we're talking about a couple things. We're talking about tamponade. We're talking about constrictive pericarditis. Another disease you're going to talk about is going to be pericardial effusion. With an acute cause of pericarditis, if the fluid comes out within the pericardium, you will see friction rub. And what is the okay, let's just review the whole thing. Where's my eraser? Yeah, let's review this. Pericarditis, inflammation of the pericardium, simple thing. Presents with a sharp pain, pleuritic chest pain, which is aggravated by inspiration and relieved by sitting up, leaning forward. Can be complicated by pericardial effusion, which is a fluid, causing friction rub, which is a scratchy sound. ST segment elevation, widespread will be seen. PR depression will be seen. Causes could be any of these. You name it, is there. Treatment is NSAID, colchicine, trying to decrease that inflammation. If uremia, then do dialysis. With the constrictive pericarditis, if you have repeated infection, chronic inflammation will cause pericardium to go into fibrosis and calcification, which will cause limited space for the ventricle to fill, decreasing the cardiac output, decreasing the venous return. When you decrease that, everything will flow back, will cause JVD, peripheral edema, shortness of breath, pulsus paradoxus, and you know what that is, and pericardial knock will be there as well. And what is pericardial knock? Well, pericardial knock is simple. That is, you have extra hard sound. So you have extra. Let's change color. Why am I going with green all the time? Okay, pericardial knock. What is this? It's basically extra hard sound. Extra hard sound on diastole. As ventricle fill to its max, it hits rigid, stiff pericardium with a knock. Right? Here's the left ventricle. Here is your, it can't fill out because you have constrictive pericarditis. So what's going to happen is pericardial knock is just an extra hard sound. Why this happens? Because in diastole, when the left ventricle is filling, what's going to happen, because the ventricle is filled to its max, and it hits when it goes to the max, it hits on the sides, which is a rigid, stiff pericardium. It produces a sound known as extra hard sound, which is like a knock. Hard sound is like knock, and that is called pericardial knock, due to the fact that you have a stiff pericardium, and the left ventricle can, when it hits the pericardium, it forms a sound known as a knock. Okay, and that is all for this one. With the calcification, you will see pericardium as a white on CT scan. So pericardium will be seen as white on a CT scan. Okay, what else you might have? For constrictive pericarditis, treatment would be your diuretic first, then surgical removal of the whole pericardium. Okay, and what else? With this metastasis, meaning malignancy, which causes constrictive pericarditis, with the malignant pericardium. So let's just write that. Malignant pericarditis is the pericardial fluid, which shows, what will it show with the malignancy if there is malignancy? Hemorrhagic fluid. Hemorrhagic fluid with atypical cells. So when you see hemorrhagic fluid with atypical cells, you're going to think about malignant cause. Okay, and that is going to be, in a nutshell, if you look at all these symptoms here, they are signs of right heart failure. You see peripheral edema, JVD. Also, you will also see hepatomegaly and pulsus paradoxus, chiasmal sign, pericardial knock. Okay, and that is going to be all for pericarditis.